Dear students, in this second part of the vignettes on local anesthetics and skeletal muscle relaxants, the important Viva voce points I will be discussing with you with the objectives to clarify the concepts, to provide topic related vignettes, to prepare and enable you to perform well in Viva voce examination, to prepare you for next, that is NEET pre-PG examination, and finally to enable you to make most out of the limited time available for interaction with the examiner. Local anesthetics. Now before discussing and asking question, let us see what they are. Now, local anesthetics are the drugs which are used to produce localized anesthesia, so avoid the adverse effects of the general anesthetics. Lidocaine is all-purpose local anesthetic agent. Prilocaine can be used without addition of adrenaline. Adrenaline does not prolong the surface anesthetic action of local anesthetics. Cocaine itself is a vasoconstrictor. It is a reuptake inhibitor, adrenergic neuron reuptake inhibitor. So it is only used for nasal anesthesia. Bupivacaine is very effective but most cardiotoxic. And currently, intravenous lipid reduces toxicity because of the rapid diffusion back from the system. Amla cream is eutectic mixture of local anesthetic, 2.5% lidocaine, 2.5% prilocaine, has a longer duration of surface anesthesia than the individual drug. And finally, some local anesthetics are developed as surface anesthetics only. Now, let us go into details. How do we prolong the duration of local anesthesia? By addition of a vasoconstrictant, adrenaline, 1 is to 80,000 to 2 lakh concentration. If adrenaline is not available, which vasoconstrictors can be used? Phenylephrine and felipressin, which is vasopressin analog. What are the advantages? Large number of advantages there. Higher local concentrations, greater neuronal uptake and block, so greater local anesthesia, lower local bleeding due to vasoconstriction, bloodless field, lower rate of systemic absorption, so less systemic toxicity acutely, longer duration of local anesthesia. Local adrenaline roughly doubles the duration of lidocaine local anesthesia by infiltration. Extended duration of post-operative pain relief because persistence of the effect, and during spinal anesthesia, added adrenaline acts as an analgesic by stimulating spinal postsynaptic alpha-2 receptors. So this is intentionally done sometimes. Even dexmedetomidine is used for this purpose. What are the disadvantages? Greater neurotoxicity, sometimes because of higher constraint cardiac irregularities, rise in spine and systolic blood pressure, tissue necrosis due to intense vasospasm, particularly when injected into digits or terminals where no anastomosis, and delayed wound healing because of ischemia or the vasoconstriction. Local anesthetics which are commonly used, one is lidocaine. Can lidocaine be used for surface anesthesia? Yes, a wide variety of dosage forms are available for its surface anesthetic use. Now, do you know any local anesthetic which has no surface anesthetic activity? Procainamide. No longer used nowadays, but procaine penicillin contains procaine. So I'll repeat, it is not procainamide, but it is procaine. Which local anesthetic is solely used for surface anesthesia only? Because of the clinical need, pramoxine is used for mucous membrane, oxytazane is used with antacid as a liquid antacid with local anesthetic, binoxinate is used for chronic anesthesia because it is non-irritating, and benzocaine is used for oral ulcers and pharyngitis, sore throat, as lozenges also, as a gel and lozenges. Now, can lidocaine be given IV? So what are the systemic uses of local anesthetic? Perhaps lidocaine is the only local anesthetic used intravenously, and it is a drug of choice for the treatment of ventricular tachycardia occurring during evolving myocardial infarction and for prevention of ventricular fibrillation and multiple ventricular extrasystoles. Now, which local anesthetic is developed and preferred in dental anesthesia? Articaine. This is a lipid-soluble intermediate potency local anesthetic with rapid onset of action and short duration of action, about 20 minutes. It is preferred in dentistry. Others are also used. Benzocaine is not used. Local anesthetic which produces inverse differential block. Generally, differential block means sensory is affected more than motor. And among the sensory, the pain and thermal senses are affected first. Now, inverse differential block is shown by atidocaine. Motor block is greater than sensory block. The most cardiotoxic, I told you, is bupivacaine, and cardiotoxicity is manifested by QTC prolongation and arrhythmia. Its analog levobupivacaine is less cardiotoxic, and another less cardiotoxic is ropivacaine. Now, one can take false statement among the four given. Local anesthetics are less effective when injected into inflamed tissue because low pH of the inflamed tissue renders local anesthetic more ionized, so less diffusible through the lipid membrane. But that is correct. Second is enhanced shift of local anesthetic to systemic circulation due to increased blood flow. Yes. Inflammatory mediators may oppose local anesthetic action, correct. But the fourth is low pH accelerates rate of tissue metabolism. That is unsubstantiated, so this may not be correct. Therefore, D is the answer. Which local anesthetic is used orally with antacids? I already spoken, oxytocin. Now, local anesthetic may produce cyanosis, prilocaine, because it is metabolized by hepatic amidase to aminophenol metabolite, which oxidizes hemoglobin to methemoglobinemia. Others do not cause this one. And the question, another question which can be asked is, what are other drugs which have local anesthetic activity and not used as local anesthetics, but they are important drugs in pharmacology? Propranolol has membrane stabilizing activity. Antihistaminics have local anesthetic activity. Antipsychotics like chlorpromazine has, quinine, antimalarial has, and all class 1B antiarrhythmics, which include lidocaine, tokenide, and related drugs, have local anesthetic activity. Now, about the spinal anesthesia, which local anesthetics are used for spinal anesthesia? Bupivacaine, amitrocaine, and lignocaine. What are the complications of spinal anesthesia? Bradycardia, headache, local sepsis, paresthesia. More important, hypotension with bradycardia, and rarely respiratory paralysis. If hypotension bradycardia occurs, which other condition would you think? Propranolol overdose. Otherwise, not many drugs would cause. Or verapamil, which is calcium channel blocker. Verapamil overdose, propranolol overdose, and spinal anesthesia. These are the three conditions which should be thought when there is hypotension with bradycardia. Now, which vasopressor is most suitable to treat spinal shock? And a vasopressor which constricts veins and arteries both is best. Mephentermine, ephedrine, midodrine are preferred. That is important. Now, this is all about the local anesthetics, and the last part of my discussion and questions would be on neuromuscular blockers. A shortest acting depolarizing neuromuscular blocker is succinylcholine. Now, the question is why it is so? Because it is quickly hydrolyzed by pseudocholine or plasma choline esterase enzyme. Now, which is the shortest acting competitive neuromuscular blocker? Mevaquirine. It is shorter than D-tibocurarine. And what is unique about this, why it is short acting and what is unique about it is because it is also hydrolyzed by plasma choline esterase like succinylcholine, even though it belongs to competitive blockers, but it is hydrolyzed. Which other competitive blockers is partly metabolized by cholinesterase, Atracurium and Cisatracurium. Others are metabolized by different mechanisms in the hepatic system. Now about succinylcholine, what are the unique adverse effects related to succinylcholine? Hyperkalemia, malignant hyperthermia with halogen or halogenated anesthetics, raised intraocular tension sometimes, intraocular pressure sometimes, and prolonged paralysis in genetically susceptible individuals. How do we know this susceptibility? Any test available? Yes, it is available. Dabucan number. Dabucan is a amide type of local anesthetic that inactivates pseudocholinesterase enzyme. And Dabucan number is a measure of ability of patient to metabolize succinylcholine also thereby. Now it can be used to identify patients at risk. Now, normal enzyme is inhibited by Dabucan to the extent of 80%, and in a genetically abnormal, quantitative or qualitative, the inhibition may be only to the extent of 20%. Therefore, degree of inhibition as a Dabucan number, 20, 30, 80, whatever it is reveals the genetic susceptibility. What is similar among these three conditions? Pancuronium overdose, myasthenia gravis, and cobra bite. There is something similar, and that is similarity is skeletal muscle paralysis. Pancuronium by blocking NM receptors, myasthenia by autoantibodies against NM receptors, and cobra toxin by neuromuscular blockade. And all shall require neostigmine for reversal. That is, they are common among these three conditions. What is the treatment of malignant hyperthermia? Malignant hyperthermia is characterized by excessive release of calcium from sarcoplasmic reticulum because genetical abnormality ryanodine receptor in the SR, and this creates hypermetabolism, muscle rigidity, and hyperthermia. Therefore, treatment of choice is intravenous dantrolene 1 milligram per kg to block release of calcium from the sarcoplasmic reticulum. Apart from that, rapid cooling, 100% oxygen, and sodium bicarbonate to treat combat acidosis. About some individual drugs, Atracurium, how it is inactivated? By spontaneous non-enzymatic degradation apart from hydrolysis. And this non-enzymatic degradation is called as Hoffman's elimination. Now, naturally, a good student should also reply another related question, and that is, do you know any other drug which undergoes spontaneous hydrolysis? Yes, thalidomide, the most potent teratogen, undergoes spontaneous non-enzymatic hydrolysis in all body fluids. So this is a question which only few of the good students can respond. Aminoglycosides accentuate this one of the toxicity of aminoglycosides. That is, they enhance neuromuscular blocking action of the drugs. And this effect is because aminoglycoside act pre-junctional membrane and block P-type of calcium channels and inhibit release of the acetylcholine. Other actions are not shown by aminoglycosides. So the correct answer is aminoglycosides block pre-junctional P-type of calcium channels. Which other drugs act pre-junctionally or on the neuromuscular junction but are not used as a neuromuscular blockers? Quinine and magnesium ion. Quinine inhibits generation of muscle action potential by stabilizing membrane, and magnesium ions inhibit presynaptic vesicular release of acetylcholine. Now, one question as MCQ is, all drugs inhibit pre-junctional release of acetylcholine except botulinum toxin A, Dantrolene, quinine, streptomycin, that is aminoglycoside. Obvious answer is dantrolene, which acts directly on the skeletal muscle and inhibits sarcoplasmic calcium release. Therefore, this is the B is the answer for this MCQ. Now, how do we reverse the excess effect of skeletal muscle relaxants? Sugammadex is used, neostigmine is used, pyridostigmine is used, dantrolene is not used because dantrolene itself is a skeletal muscle relaxant. Now question comes, reversal may not be required for very short acting drugs like succinylcholine and mevacurium, but it may be required for longer acting drugs, longest being pancuronium. So what is Sugammadex? It is a modified gamma cyclodextrin, which is a chelating agent that binds in equimolecular concentration with steroidal neuromuscular blockers, that is rocuronium, pancuronium, vicuronium, and removes rapidly rocuronium from the circulation and from the muscle membrane. Therefore, quick reversal of relaxant effect is seen, and the entire complex becomes water soluble and excreted easily. Now, the second group of drugs which are skeletal muscle relaxants are centrally acting drugs. We are called as spasmogens and spasmolytics and antispasmodic drugs. Mechanisms of actions are multitude, and one of the mechanism is GABAergic mechanism, GABA being the central inhibiting neurotransmitter. Baclofen, diazepam, thiocolchicoside, and many others are GABAergic acting drugs. Tizanidine is also a centrally acting drug, but it is central alpha receptor agonist. That is, it acts as a central alpha 2 agonist and acts on spinal supraspinal pathways to relax the polysynaptic pathway, acts on polysynaptic pathway and relaxes the muscles. Now, if you are given a question, a structured question to match baclofen, diazepam, riluzole, methocarbamol, rocuronium, succinylcholine with their therapeutic use, then this how will you do it? And this is the answer for this. Baclofen is a drug of choice for multiple sclerosis. Diazepam is used intravenously in the treatment of tetanus. Riluzole is developed for amyotrophic lateral sclerosis. Methocarbamol is used commonly with analgesics in the treatment of painful muscular spasms. Vicuronium is used invariably or atracurium in patients who are on ventilators. These days, with the COVID-19 infection, these drugs are commonly used. And finally, succinylcholine is commonly used for short surgical procedures such as endotracheal intubation. Botulinum toxins are the important potent toxins, and currently botulinum toxin A in the name of botulinum toxin A is used. It acts by blocking vesicular release of acetylcholine at the presynaptic area, and it also inhibits release of co-transmitters. Actually, it is a proteolytic enzyme that cleaves the amino acids from two fusion proteins that are needed to fuse the vesicular membrane with the nerve terminal membrane, that is where release is actually occurring by exocytosis, and thereby it inhibits the release of excitatory acetylcholine, so no contraction occurs. Currently, a large number of diseases, muscle diseases, where local spasm is there, they are being treated by botulinum toxin A. Blepharospasm, dystonia, writer's cramp, torticollis, focal tricks, strabismus, hemifacial spasm, resistant tremors, autonomic disorders, axillary hyperhidrosis, palmar hyperhidrosis, gustatory sweating, urinary incontinence not treated by the anticholinergics, tolterodine etc., then we can use botulinum toxin into the bladder muscles. Currently, Facial wrinkles are treated with botulinum toxin, and it is cosmetically very commonly used by a local facial injection. Effect of injection lasts for about 3 months. Therefore, one looks young and fresh without wrinkles, without facial furrows. Botulinum toxin may also be used in chronic migraine. Now, name a drug which acts directly on skeletal muscles, dantrolene sodium. What is used? Spastic upper motor neuron disorders, malignant hyperthermia, neuroleptic malignant syndrome. But why it is not commonly used? Because the diseases are uncommon, and second, because dose limiting reduction in muscle strength, normal muscle power is also reduced, and that may affect actually activities, particularly in elderly bedridden patients. Therefore, it is less often used, but it is certainly a very good drug for the treatment of malignant hyperthermia, neuroleptic malignant syndrome. Thank you for attending this session. More presentations will be uploaded in due course of time. Good day.